Welcome everybody to the online seminar series, Machine Learning Needs Mathematical Optimizations. So today we have Professor Christina Pagel from the University College of London. So she is an operational research full professor there. She's also the director of the Clinical Operational Research Unit at the same university. And this unit applies operational research, data analysis, and mathematical modeling to problems in healthcare. She's also an honorary researcher position within the Great Ormond Street Hospital in London. Christina has an impressive list of publications. It would be very, very long for me to describe it, but just to give you a sense, Science and the Lancet publications, you can find them often in her Google Scholar. She was awarded the Lynn Thomas Impact Medal from the Operational Research Society in the UK. So that's also very impressive. And she has also won several awards for her public engagement in science during the COVID-19 pandemic. Finally, Christina is a Turing Fellow from the Alan Turing Institute by special appointment. So we have the great pleasure to have you today here, Christina. And for the audience, so that you know, we follow the similar rules as usual. If there is a very, very urgent question, please put it in the chat and we will, I will read it to Christina. But normally we handle all the questions towards the end of the presentation. Thank you so much for making time to speak to our audience today. And the floor is yours.
Yeah, well, thank you for asking me. And it's a pleasure to talk about something other than COVID. So this is a project that just finished about 6 months ago, where we use location allocation optimization to support specialized children's ambulance services in England and Wales. And I quite like it because it's kind of a combination of kind of classic operational research methods, but also working really closely with the services to make sure that we were answering things that were useful to them and working with kind of statisticians and also patients, and not patients so much, but their families. So I'm just going to go through just the background to kind of explain to you, how it's set out in England and Wales. And then we kind of did a very initial simple model just to get an idea of, what the current situation was, which was actually really useful to kind of focus minds. Then we extended the model quite significantly over the following year, and then applied that to actual service scenarios that came from the people running the service. So I'll kind of go through that and then I'll just summarize at the end. And also just say the bulk of the work was done by 2 research associates and not me. So I was kind of doing the kind of working with the services to do the scenarios. So starting off with the background, it's part of this big study called the PICRT study, which was looking at emergency pediatric intensive care during transport. So what this is that in 1997, pediatric intensive care units in England and Wales were centralized. So what they did is they stopped hospitals each having their own, and I think there are about 30 hospitals now in England, across the whole of England and Wales, that have a pediatric intensive care unit. But to do that, they had to set up what are called pediatric intensive care retrieval teams. So when a child gets very sick and goes to their local hospital, which is called a DGH or District General Hospital, and that hospital feels like it can't care for that child, they will call for a PIC retrieval team to say, can you pick up this child and take it to intensive care? And those retrieval teams are staffed by intensive care specialists. So that all started in 1997, and the national guidelines say that teams must reach the bedside of the patient within 3 hours of accepting the referral. So when the hospital calls the retrieval team and says, we've got a really sick patient, and the retrieval team agrees that that patient is really sick and needs intensive care, they then have 3 hours to get to that patient at the local hospital. So the kind of thing motivating this study was, that guideline was basically expert consensus, and it wasn't really based on any data. So the question is this guideline too high? And it was kind of, the idea was in adult there's a concept of kind of the golden hour, where if you can reach someone within an hour, you have a much better chance of saving their life. And it wasn't clear whether this worked for children who were already in hospital by this stage? And also, you know, if the guideline has to go down, or even if currently, is there a better way of allocating that centralized services geographically to meet that demand? So this is what it looks like. So these are all of the district general hospitals in England and Wales. And here are the PICU locations, so the paediatric intensive care units. And you can see they're very heavily concentrated in major cities. And so there are parts of the country where you don't have any PICUs. And this is where the current retrieval teams are located. So they're always co-located with a paediatric intensive care unit, but they're not, but not all PICUs have a PICRT. There are only 11 locations in the country. And again, these, the locations were not chosen based on data remodeling, they were chosen based on experience and who happened to kind of be in the room at the time. And so this is kind of the service cycle. A patient referral is accepted, then the retrieval team has to be there, because basically you don't have many teams. It's not that high a demand, and then they have to mobilize, and then they have to go to the local hospital and pick up the patient. And that's when the patient starts receiving ICU level care, when the team arrives. And they often spend 3, 4, 5 hours at the local hospital providing intensive care type services and stabilizing the patient before they then take that patient off to pediatric intensive care. So it's not like kind of picking up someone from a road traffic accident. And then once they've transported them to the PICU that patient's going to, they then have to return to base, and only at that point are they available for a new referral. So here's an example kind of a short round trip in London. So here is the PICU and the retrieval team. They get a call from this hospital, go to this hospital, take the patient from this hospital to the PICU up in Paddington, and then they have to go back to base, and then they're available for the next journey. So, you know, we thought that, you know, location allocation models are kind of a perfect solution for kind of looking at these kind of questions. And the initial thing we looked at was, does the current configuration of retrieval teams meet the standard time to bedside within 3 hours? You know, are we actually meeting that standard? Is it possible to meet that standard by the current location? And if it turned out that actually the time to bedside standard should be shorter, would the current configuration meet a shorter time to bedside standard? And if not, and you need more retrieval teams, where should they be located? And then finally, do we actually need 11 retrieval teams, or could we make do with less, because they're expensive things to run? So the kind of basic way of applying it to location allocation modeling is that your resource hubs are the PIC retrieval teams, and where do you want to locate them, and your demand points are the local hospitals. And then what we're saying is that any PICU, so about 30 PICUs and 11 current retrieval services, any PICU could potentially host a retrieval service, but they can't be hosted anywhere else. So this is the initial simple model. We made various simplifying assumptions. The first one is that a team is always available to meet a referral, which is very optimistic. We assumed a constant mobilization time of 30 minutes, which is what the median time is in England. We also assumed that once you got to the local hospital, it takes about 10 minutes to get out of the ambulance, find the main bit hospital, and then find the patient. We assume a constant travel time, and those travel times were just obtained from Google Maps API. And we also assume that you can only use an existing PICU site as a potential location, and that came from service planners. They said it makes so much more sense because the staff in PICU and on a PICU retrieval have the same skills. And then we also assume that patients are transported to the closest PICU, which isn't necessarily the case. So this is kind of the time to bedside, your mobilization time plus journey time plus time from arrival to bedside. And so really, with these kind of fixed times here, you need a journey time of about 2 hours and 20 minutes to meet the standard. So as for data, we had the list of all hospitals in England and PICRTs and their postcodes. We got the journey time between all of them, a massive two-way lookup table from Google. And we also used the demand for PICTs, the retrieval team services from each local hospital for 1 year, kind of weight optimization, because basically you want to make sure the hospitals that have a lot of demand are weighted higher than hospitals that barely use the retrieval services. So here again are just the current PICUs in red and PIC retrieval teams in blue. And remember, all of the blue dots are also a pediatric intensive care unit. And this is the demand for the services from all the local hospitals. And you can see that actually the demand is quite variable. So there's some hospitals here which hardly ever use it to transport, and some that have quite heavy use, particularly around London and central England. And we used a P-median location allocation model. Basically what we're trying to do is minimize over all demand hospitals, all candidate locations, which in this case are existing PICU locations, and then this kind of product, which is demand. This is the travel time between your local hospital and your retrieval team, and then just this indicator variable to say, is that retrieval team actually, is that location actually operating? And then your decision variables are xj equals 1, which is if a potential PICU is actually a retrieval team location, and then yij, which says local hospital I is served by retrieval team J. So it's a reasonably simple model. It just has a few constraints, which are your kind of standard constraints, saying that each demand node is allocated to one and only one retrieval team. The number of total retrieval teams is a fixed constraint that's given by the service, and you can explore it for different values of P, but that is an input into the model. You cannot assign a local hospital to a location that isn't operating. And this is a kind of a service constraint. So basically, we actually relax this later on, but they were saying, you know, it's a lot of effort to move a retrieval service. So what we started off by doing is saying that as long as you have at least 11 retrieval team locations, then keep them where they are now, and only start looking for new locations once you've allocated them. But as I said, we did relax that later on. So this is how the model allocated the local district hospitals to the retrieval services. So each color corresponds to a different patch, and these blues are the retrieval teams. So you can see, you know, it's reasonable geographic distribution. And actually the positive thing is that this distribution was a relatively close match to the actual distribution, the actual allocation of district hospitals to the retrieval team. So that was kind of all good and consistent. And this is under the current configuration, the kind of average time to bedside. And so 1 hour, if you can get there within 1 hour, it's green. There's hardly anywhere in the country that you can get to within 1 hour. And that's basically because of the 30-minute mobilization time and 10 minutes the other side. It has to be somewhere within a 20-minute drive, which really isn't that many places. You have quite a lot of places with yellow, which is 90 minutes. And that's basically the places that are around cities and suburbs. More places that are within 2 hours, and then obviously the further away you go, the more rural you are, the more you get to 3 hours. And one of the main things that came out of this initial piece of work is there are 5 hospitals where it's absolutely impossible to get to within 3 hours, and they are this kind of far corner of Norfolk, because the closest retrieval teams are basically in London, and it's more than a 3-hour drive. And again, kind of the tips of Wales and the tip of the southwest of England. And that's because the local, the nearest retrieval team here is in Bristol, and it's just really far. And if you know, when we talked to the services, they said, yeah, you know, those hospitals are really problematic. But actually, these two and this hospital have quite high demand. So this is already a situation where you cannot fulfill that standard for these hospitals. We then looked at, okay, well, if we could put these 11, 1 second. Justin? Oh, sorry. Oh, did you just put it in? Oh, great, thanks. Sorry. Right, I'm back.
No worries. Yeah, thank you.
Right, so you've got these best 11 locations. And what they did was added an extra location in London and actually moved the 2 existing ones to 2 new hospitals. And what they did, the current locations in London are right in the middle of London, like bang in the middle. And London traffic's really bad and takes a long time to get out. So what it did is it reallocated them, those 2 to 3 locations that are in the periphery of London. So it's easier for them to get out, but they can still get in. It also added a Cambridge location up here. And what that meant, it allowed you to cover this bit of England within the 3 hours. The north remained largely unchanged, and that's partly because there's just actually not that much choice up there. In the you know, you have where you have more than one PICU, it's in the same city, and the cities aren't that big geographically. So actually, not much changes in the north, but you can get to everywhere within 3 hours. And unfortunately, there's not much you can do about these locations in Wales and this location in southwest of England. The only choices that you have for locations here are Bristol or Cardiff, and neither of them are that helpful to you. And this is just looking at the times to bedside. So you can see as you go from the current to the best, you can now reach these 2 in Norfolk, but you still cannot reach these 3 here. And then we kind of looked at it for all these different numbers of potential locations for retrieval teams, so all the way up to actually you could have a retrieval team at every single PICU in the country. This solid line is using the 11 current locations before you allocate any new ones. And this dashed line is you could put them anywhere among the PICUs. And this is the percentage of demand covered. And the coloured of lines is what happens if you move from the current 3-hour standard to shorter times to arrival. And so actually for the 3-hour standard, although you can improve it a bit, actually you can meet 98% of your demand currently, because the only demand you're not meeting is those 5 hospitals that I showed you. As you try and get there quicker, it becomes much more problematic. And you can see that actually once you get to 11 or 12 locations, you're not adding anything by adding locations. And that's because PICUs are in cities and the cities aren't moving. So it doesn't really matter if you have another PICU, the distance they've got to drive just means that they can't get there. But what you can see is that you can get quite a high benefit from moving where your current locations are. So if you try, say, the best 8 locations, you can kind of get this table. This is the percentage of demand covered. Within 1 hour, you just can't do it, right? And then gradually, as you increase your threshold up to the current, you can meet more and more of your demand. And what you can see is that the best 8 locations are better than the current 11 locations in every case. So that kind of shows you how actually you can do better just by putting them in a different place. And this is where they would be. And what's quite nice here is that the current 2 London hospitals split north-south, but this is showing you that actually if you're only going to have 2 London hospitals, they split east-west is a better split to get. So that's kind of where we kind of got to with that. And then the other bit of the project, which was actually using a lot of historical data to understand the importance of that time to bedside on patient outcomes, and the primary outcome being mortality within 30 days. So this population is literally the sickest children in England, and they have about 8% of them die within 30 days. And what you see is that the probability of mortality, this is adjusted for lots of different variables by time to bedside. There really isn't a pattern. And so based on this, we concluded that there was no evidence to support further reducing the time to bedside standard. So the 3 hours looked like it was working okay. Very few patients actually took longer than 3 hours. So we didn't really know, or if they did, it really wasn't longer than 4 hours. So you couldn't say, well, 6 hours is really bad and so on. So it felt like there was no need to increase the 3-hour standard, but also no need to decrease it. So in that sense, the questions that we were looking at before became less relevant, because actually the current standard was okay, and we could meet 98% of that demand. So then we kind of worked with them to think, okay, well, what else could we do? And one of the things that we hadn't looked at all was how many teams you need to staff each location. So we'd assumed that you always had a team available. We know that's not true. And so given, if you could incorporate that into the model, you could say, well, okay, well, how many teams do you actually need to meet your demand? And then if you could do that, can you improve winter? So this is just up to 2012, but this is true throughout. Every December, demand doubles in pediatric intensive care without increasing your resources. And it causes a real problem. So the question is, okay, well, actually, if we could staff a few extra teams at an existing location, could we deal with that demand? So that's what we kind of set out to do. So we had to extend the model to do this. So if we go back to the retrieval team journey, you can see you kind of got the retrieval service accepting the local hospital. It's available and mobilizes, arrives at the hospital, transports the patient and returns to base. But there are all kinds of things that are complicating here. So sometimes you have to wait for the next team. So that was kind of what we wanted to do. We wanted to incorporate waiting time for the next team and allow different numbers of teams at each station. We wanted to incorporate variable journey times, and not just motivated by Google, but actually taken from data, because they do collect data on journey times. Given that you're in an ambulance that has access to a siren, you can imagine that the Google times aren't necessarily that useful. And then we also wanted to look at other legs of the journey. So at the moment, we'd only consider time to bedside, but especially if you want waiting times, you have to consider the time to PICU and time back to base, because until they've done that whole journey, they're not available for the next one. And again, those journey times came from the data. And then we also got rid of the assumption that they always went to the closest PICU. So what we did is we looked at the actual data of where patients went, and we used that to inform the probability of which PICU a child from a certain hospital would go to. And then we also, in our scenarios, looked at different levels of demand. So demand for PICRT services varies a lot by season, which I've just showed you. It also varies by time of day and day of week. So it's lower at weekends, it's lower at nighttime. So how did we do that? So for the stochastic journey and now mobilization times, we just used it from the data to get the mean and variance, check that, and then we use this predetermined distribution, which we decided to use a log normal, which seemed to fit the data reasonably well. And then for the objective function, we used expected journey time, and we also put in the possibility of using stochastic constraints. So you could say, for instance, we need the model to optimize it, so the probability of getting to bedside within 3 hours is more than 90%, for instance. Now, in the end, we didn't use these constraints, but we have put into the model the flexibility to incorporate them. So what this did is it just changes the objective function a bit, where you now have all the journeys. This is the time to bedside, time from local hospital to receiving hospital, time back to base, and we've included the waiting time. And it's the waiting time that's really crucial, but it's quite hard to incorporate. As you'll see, it's highly nonlinear, and it kind of depends on all of these three as well. But if you want to optimize the number of teams at each station, if you want to answer that service question, you have to find a way of incorporating it. And so we did this by saying, so each location J, you have a certain number of teams, which are effectively the servers. You assume that patient requests a Poisson, which is reasonable, they're emergency situations. And then you have kind of weighted journey times, which are your service times. And for that, we just followed the general distribution, because it's certainly not a simple or tractable distribution, because it's kind of over 3 whole legs and all the rest of it. So you have a kind of MGCQ. And so what we did is we used what's called Kingman's formula, and that gives you kind of an expected waiting time for a kind of a general queue, GGCQ, based on these parameters, and these parameters we can calculate from the data. So that's what we did. But it is highly non-linear because the number of servers, which is what you want to know, is here several times as an exponent and as a factorial in the denominator. So when we did the optimization method, you had to use heuristic methods. It's non-linear, it has loads of variables. We've got, over 200 district general hospitals, potentially up to 27 different PICRT locations. And so what we did, we kind of ended up using a genetic algorithm. I mean, there's more than one way of doing it, but this is the way that we did it. And we kind of used the 2 steps in the genetic algorithm where you, for any given set of retrieval team locations, you worked out the allocation of local hospitals to it and the times. And then within that set, you then optimize which of those sets of operational retrieval locations you're going to use. And we do that by assuming they each have several teams so that they're not really constrained by the number of teams and waiting times. But then what you do is once you have your optimal locations, you then remove the teams one at a time, and you pick the team to remove by picking the one that is the smallest increase in the objective function. It's always going to get worse if you remove a team until you get to the number of teams you actually want from your constraint, which is a service constraint of how many teams the service is prepared to pay for. It's not the prettiest way of doing it, but it was the way that worked in a reasonable time frame to run the model, and we did quite a lot of sensitivity analysis around it and showed that it gave you pretty kind of robust and consistent solutions. And that's now published in Health Systems in great detail. So how did we apply it to the service scenarios? Well, we kind of talked to the clinicians and the commissioners who were running the service. It's a national service. And we kind of looked at, well, okay, do we know that demand varies by season and time of day? And really, the idea is we want to plan for periods of highest demand. And so we considered just the daytime, and we considered it kind of in winter, which is for children is November, December, January, because demand always starts increasing in November. And then we kind of also looked at non-winter as a comparison, which was February to October. We kind of picked reasonable constraints and said, okay, we're not going to go for fewer than 7 locations, which from the simple model, you could see that that led to a really drastic drop-off in meeting demand, even under really optimistic assumptions. And we also didn't really go above 15 locations, because again, from the simple model, we could see that going higher than that didn't give you any added benefit. And the question we wanted to know is, what if there was flexibility to add resource in winter? So currently we have 11 locations, and there are 16 teams spread across those 11 locations. And we looked at 4 questions in order. So the first one was, if you had 16 teams and you had 11 locations, if you put those 16 teams differently among the 11 locations, could you improve performance? Then could you improve performance if you could allocate those 16 teams among a reduced number of locations, not changing locations, just dropping some, which is an easier thing to do operationally? And if you had the option to add teams, would you add them? How many would you add, and where would you put them? And then finally, what if you just start from scratch and change locations completely? So this is kind of the result for non-winter daytime. So this is kind of the not really busy period between February and October, 8 a.m. to 8 p.m. And this is average time to bedside. And this is the number of overall teams. And the different lines correspond to different numbers of locations. So in this red dot is the average time to bedside from 11 locations and the current 16 teams. So almost 110 minutes, almost 2 hours is the average. If you reallocated those 16 those 16 teams across those 11 locations, you get to this green dot, and you can see you can take almost 10 minutes off your average time to bedside just by switching teams around the existing locations. And it wouldn't cost you any more money, but you can do that way. And then if you had fewer locations and different numbers of teams, actually the main way of learning from here is that you can cover 98 to 90% of demand within 3 hours for all of these scenarios. And it's saying actually you actually have quite a lot of flexibility in how you want to configure your service and get pretty much the same performance. I mean, a minute here or there isn't really going to be life-shattering. Then this is winter daytime, so this is when things are really busy, and you're looking at average waiting time for available teams. So remember, demand doubles in winter, so it's not surprising that you have to wait longer. And again, this is the current 11 locations, current 16 teams. The average waiting time is more than 30 minutes. So that's before you can even start to mobilize. And the key thing here is that the waiting time is always shorter with more teams. And that's just kind of a standard result of queuing theory, really. The more teams you have available, the more you are to have someone there. But this doesn't necessarily mean that your time to bedside is always shorter with more teams, because if you have more teams, if your locations are fewer, they might have further to travel, and you'll see that in the next slide. So this is the average time to bedside. So this is waiting time plus journey time. And again, this is the current 11 locations, current 16 teams. This is 11 locations, and this is actually not 16 teams, 11 locations, several different teams. 10 locations, 9 locations, and 8 locations. And you can see for smaller numbers of teams, 8 locations is better. But as you get to more teams, it's not. And that's because once you have enough teams, it kind of offsets the fact that you have less far to travel with more locations on average. But you can see here at 16 teams, you get quite a big benefit when you move to 8 locations, and that's the efficiency in being able to double up on teams. And that's kind of a standard, well-known result from queuing theory is that having 2 servers instead of 1 server, rather one queue is better than 2 queues if you have 2 servers, and that's kind of what this is telling you. The other thing to notice from here is that if you have 19 teams, they're all roughly around 100 minutes. Then you're matching the average time to bedside of 16 teams outside of winter. So if you went back to the other graph, you would see the average time here was about 100 minutes. So if we looked at scenario 1, where you're just redistributing 16 teams among 11 locations, in winter daytime, which is the highest demand, you reduce waiting time by 13 minutes, and you reduce time to bedside and PICU by 13 minutes on average. And the proportion of children you reach within 3 hours, and this is a really big thing actually in winter, is that it increases by 10 percentage points. It goes up from 87 to 97%. So that's a really big win for actually a minimal amount of work. If you then redistribute those 16 teams among 8 locations instead, so drop some locations, you can get the following. So compared to your best optimal teams at 11 locations, you reduce waiting time by another 10 minutes. Your average time to bedside and PICU reduces by 7 minutes. So it's lower because some hospitals you need to travel further to get to. But your proportion of children reached within 3 hours actually only increases by 0.5 percentage points. So at this point, you're getting marginal benefit on the actual standard that you're trying to meet. And this is if you can add more teams. If you added 3 teams across those 8 locations, then compared to your previous optimal, so you had 8 locations, 16 optimal teams, and now you're going to give them 19 teams, you can reduce waiting time further by another 5 minutes. And that's basically just having more availability. And the same thing, you reduce your time to bedside by another 5 minutes as well. And that makes sense because you're not actually changing location. So there's no reason it would change your journey times. And the proportion of children reached within 3 hours, though, is the same, because what it's not doing is it can't compensate for really long journeys. So I think that's always something to think about. So if you're thinking about proportion of children reached within 3 hours, for the people that are really far away, that's a journey time problem. That's not an availability problem. And if we look at the comparison across the scenarios, so this is the improvement compared to the current situation. So this is the average improvement in minutes compared to the current 11 locations, currently 16 teams in daytime winter. So this is if you have the current locations and when you move where those 16 teams are, you get this kind of 12-minute, 13-minute improvement. You get a bigger improvement if you just move down to 8 locations and 16 teams. So that's your benefit of doubling up on teams. If you add 3 teams, you get another big benefit in waiting time. This is just the current location with 3 extra teams, and you'll see why I've picked that at the end. And this is actually if you can go to any location, you get a bit of a benefit here, but not a massive one. This is the reduction in time to bedside, which is actually what you're kind of optimizing. So you can see here that the difference between, this is what I'm kind of focusing on, the difference between 8 locations and 19 teams and 11 locations and 19 teams has fallen. And that's because, as I said, with 11 locations, some places are just closer, so your journey time is reduced. And if you look at the improvement in the percentage of children reached in 3 hours, you get a really big benefit in just switching your teams around. And then you kind of get these marginal benefits. But the key thing is that actually the proportion of children you can meet, you can get to within 3 hours between 8 locations and 19 teams and 11 locations and 19 teams is almost exactly the same. And the reason that matters is because there's a lot of politics involved. And if you went from 11 locations down to 8 locations, there would be outcry among the locations that currently offer it. I mean, that's just the way things are. People are very, very emotional about their local children's hospitals and children's services. And so unless you can show that there really is a massive benefit in moving from 11 locations to fewer, it's not worth it. It doesn't give you benefit. But if you're thinking about the number of teams, that's much less political. You can add teams, that's just a question of money. And even moving teams around is a little political, but not kind of this massive outcry of closing a service. So this is what it would look like. If you have the current allocation in daytime across, so you can see these are the PIC retrieval services across basically in different cities in England. All you're doing from getting from the current to the best configuration is swapping the number of teams between Manchester and Newcastle. I mean, that's literally it, and you're getting a really big benefit. You're giving one of the Newcastle teams to one of the Manchester teams. And the reason that you get that benefit is mainly because Manchester serves a wider area and has a higher demand. In winter, if you want to add 3 teams to this distribution, you add a team in Birmingham and you added a team each in London, which actually we were quite surprised about. We kind of assumed that London was reasonably well resourced, but it turns out that the demand is concentrated in the southeast of England, and this is where if you add teams, you get the biggest benefit in London. So just to kind of summarize then, location allocation modeling is a really powerful tool to help service planning. But it does need to adapt to real life questions that services have. So it doesn't have to be the prettiest optimization model. It doesn't have to be the cleverest algorithm. And it's not really up to you to kind of say what are the objectives. And it has to adapt to evidence. So like when we realized that 3 hours didn't have to get reduced, it completely changed the kind of questions you were asking. And I think one of the things that came out of it is actually there are many different configurations of service that allow, the vast majority of children to be reached within 3 hours. So I think that's quite reassuring. And actually, the one they've got now, it isn't too bad. In general, more teams in fewer locations is more efficient than the same number of teams in more locations. I mean, that does follow directly from queuing theory, and makes sense. But actually, for service planners who don't know about queuing theory, it's quite a nice kind of rule of thumb just to kind of talk to them about. And this is kind of what I'm saying, that although 8 or 9 out of the current 11 location works a bit better for the same number of teams, the differences are not really large enough to be worth the potential restructure. There is pain associated with restructuring. And even though if you completely could choose, if you were starting from scratch, you wouldn't necessarily pick these 11 locations, the effort involved in setting up new locations is not warranted because the improvements aren't big enough, and they don't lead, there's no real evidence that they would lead to massively better outcomes. But I think the kind of the final thing that is quite important, and that I hope they are actually going to do this year or next year, is that an extra 3 teams distributed across the country, so 1 extra each at 3 locations, would compensate you for the extra surge in demand in terms of waiting times. And that's quite a big deal, because actually at the moment you get quite a lot of refusals in winter where a service is too busy and it has to get punted to a different service, and that's not optimal, and it causes a lot of stress both for the services themselves but also for parents who sometimes do then have to wait a long time at the local hospital waiting for their child to be seen to. And the other thing is that in general, when thinking about resource and allocation decisions, it pays to think nationally and not just locally. And I don't know what it's like in other European countries, but in England and Wales, the PIC retrieval service is a national service. But when it comes to funding the teams, those are local funding decisions. And so when I said, okay, well, if you had 3 extra teams at 3 different locations, that wouldn't be a decision taken nationally. That would be each local service going to their local commissioner and saying, can you fund me an extra team? And actually, that's not optimal. So that's the kind of thing where you have to think here, okay, well, actually, if you're thinking about resourcing, you do have to take into account the whole picture. And if you are going to try and disaggregate it by region, you're going to end up with a suboptimal result. And that is it. That's the end of the talk. I just wanted to acknowledge everyone else in the team and also the researchers who did the actual optimizations.
Thank you very much, Christina. Yes, so now we are going to open the floor for questions that the audience may have. So as usual, you please raise your hand with the tool and we will give you access to the microphone and the camera. Thank you so much. Christina, while other people are having stating their questions, so you talk about that we need to adjust to the needs of the user, the optimization, and you have designed, say, some heuristics for that. There is this area of, say, explainability in machine learning, and I was wondering whether this explainability in optimization, you know, when we say we make a planning and then we have to talk to the planners and then we have to communicate with them. Is that something that you have to also do? So say explaining the output and trying to model a heuristic that is easier to be understood by the planners?
So I would say that they were supremely uninterested in how you did the optimization. But what mattered was that the results made sense. And that's where actually, because we started off with quite a really simple model and started off by just modeling what's happening right now, and when people can see that that matches their current experience, that builds trust. Yeah. And then you basically take them through the steps by showing them the results and not the method, I suppose. And and sometimes you've got some kind of quite funky things. So something like occasionally you'd get like one hospital that was allocated to a completely different hospital to all of its neighbours. And they go, what's going on there? And it turns out, you know, it's on a motorway, and actually it's a bit quicker, like maybe a couple of minutes quicker to go a bit further than to go to a different, you know, And so they definitely would pick up on anything that they thought looked quirky, and you would have to be able to explain that. But in terms of, like, especially once we're getting to like queuing theory and genetic algorithm, they weren't that interested. But things like saying, look, if you have the more teams you can have at a single location, there's a benefit. There's a benefit to centralizing. And kind of explaining how that worked, I think, is quite a useful rule of thumb for them.
Thank you very much. We now have somebody who would like to state a question. So all about it. Christina, the other Christina, is going to give you, say, access to the microphone and the camera. So do you have now access, all about it?
Okay.
Yeah. Okay.
Yeah. Okay, good. This model, can it be used to situations like we had in 2020 during the COVID, where we have a limited hospital and bed facilities, and we have more patients of COVID. Can this model help in such a situation? Thank you.
I mean, I think that's a really good question. I think for COVID, I think you'd probably want to start with a different modeling approach, and that's because one of the reasons we could do what we did is that the pediatric intensive care retrieval is a relatively small service. You know, it's 11 locations, and a few, 16 teams, and we could constrain it and say, okay, well, we're only going to look at allocations between this and this number of teams and this number of teams. And if you stop doing that, and the way that it was coded up, it wouldn't have been able to cope with hundreds of potential locations or hundreds of potential teams, which is what you're looking at if you're looking at national adult ambulance services. But there are ways of doing it, and I know that people have been doing that, and particularly not so much around the ambulances, but around inter-hospital intensive care transfer. So I don't know if that happened in other European countries, but certainly during the height of the waves in England, you would have to move patients out of intensive care from the really hard-hit regions to different hospitals, which is a very suboptimal thing to do. You don't want to have to move critically ill patients in an ambulance, but that's what they had to do. And if there was a way of distributing that in the most efficient way possible, that is a really important contribution of operational research. But what I don't know is whether that actually is how that did contribute to what they did in January.
Thank you very much for the question and the answer. So is there any other question from the audience? Yes, just wait for a bit. Yeah. But if not, we have been very pleased to have you today in the online seminar series. It's a very important topic, and actually, some of the audience, they are also in the location theory area, so you have attracted these profiles. Thank you very much for coming today, and we hope to see you very soon in another event.
Thank you for having me.
Thank you. And thank you to the audience. So next week we will have a young online seminar series, and we will be back with the senior one in 2 weeks from now. Thank you so much, and see you soon. Yeah.